WhatsApp group. Thank you so much for accepting it. So I do not want to stand between you and the interesting CME coming up. Thank you, PRC sir, for joining with us and accepting to inaugurate the microbes article. Thank you all so much.
Balashankar sir has joined if you want him to talk.
Yes. Next to felicitation.
Balashankar sir, please.
Yeah.
Before we start.
Sir, you are muted, sir.
Sir, you're muted.
Sorry, sir, you are muted.
Yeah. No.
Good evening, everyone. Good evening. Very good evening.
Sir.
Very nice to meet you all through this webinar. Thank you very much for inviting me to this CME, which is first of this year's infectious disease chapters webinar CME, and it is Dr. Narmada's activities are going to be excellent. I can even predict that. And this year, I think it will be filled up with so much of activities on infectious disease chapter. And very happy that this is getting registered also as a body ID chapter of Tamilnadu, and it is fantastic that it is getting registered. And really, so much has been done since the inception of this ID chapter of Tamil Nadu from Dr. Venkateswaran sir. Janani madam has done an extremely good job for the past 2 years, and now it is a time for Dr. Narmada to carry the torch, and it will definitely reach very good heights in this coming years. I really congratulate Narmada in advance for that. And today is a day where we are going to learn something about an old disease, but concepts are changing every day. Primary complex, what we call now, it is been called a childhood tuberculosis. It is supposed to be the bread and butter of yesteryear's pediatrician. Now we are very cautious in making the diagnosis, and unless it is there's a definite proof of tuberculosis infection, we are not going to start TAT nowadays. So there is going to be a lot of dilemmas in making a diagnosis of tuberculosis, and because we are going to give 4 drugs for tuberculosis in children, so all the drugs are not that safe. So the diagnosis is going to should be very precise in making. We should be very precise and very clear in making a diagnosis, and it should not be a costly mistake also if you omit it. So it is something like walking on a tight rope. So today we have got a beautiful scientific personalities. That's Anu Singhal, one of the authorities in infectious diseases in India, who has come here to give a lecture on update of childhood tuberculosis. And we have got an interesting panel discussion from Dr. Vidya Krishna, Janani, Vaishnavi, and Abhinesh. I think we all have a very good academic feast today, and expecting a very good scientific evening this evening. Thank you very much for the opportunity.
Thank you, sir. Thank you. I request
Dr. Murugan sir to say a few words.
Thank you very much, ma'am. I think I should not come in the way of the wonderful session and giving a long talk, except to say that the ID chapter is probably the most vibrant chapter under the previous years with under Dr. Jani, and now under Dr. Narmada, and of course yourself and the rest of the team. I wish you a great success, and all our pledge our support for the chapter. Of course, I'm also part of the chapter. So thank you very much for this opportunity. I'm sure that we all have a lot to learn in tuberculosis, so we will really enjoy the session. Thank you very much.
Sir, PRC sir.
yes, sir.
Good evening, and thank you for the opportunity. So I don't have anything much to say. Best wishes to Dr. Narmada and Dr. Dana for taking over after the illustrious last year, headed by Dr. Janani. So all the best. And
Hello.
Hello.
Hello, sir.
Connection is not okay. I think we should start.
Ma'am,
Don't.
1 minute, ma'am. We are just waiting for him to inaugurate the. Yeah.
And very.
I think Narmada, next slide.
Yeah. So we are inaugurating, we wanted PRC sir to inaugurate the microbes.
Yeah.
Yeah.
So
Yeah.
this edition we focus mainly on hospital
Be happy
acquired
to.
infection.
Dana, 1 minute. PRC sir has joined.
Yeah.
Yes,
Yeah,
sir.
I'm here. So I'm very happy to inaugurate and present the first newsletter of the year, Microbes. So happy year throughout the year, full of academic activities. All the best to both of you.
Thank you, sir.
Thank
And
you, sir. Thank you.
Thank you. We really congratulate Dr. Arun Vikraman, the new editor who
Yeah.
has joined us and has done a fantastic job. And I'm very sure you'll all enjoy the very carefully selected articles curated by Dr. Dana.
Yeah, this edition we focus mainly on hospital-acquired infection. So we should not think hospital-acquired infection only in the major hospitals only. Even in small clinics, we need to focus on infection control. We chose the topics like importance of hand hygiene, how to practice isolation policies, and sterile aseptic techniques you have to follow during the procedures, etc. I think you will enjoy this edition. Thank you.
We acknowledge the presence of Dr. Neminathan and Dr. Ilarasi ma'am and Dr. Painiraman sir who has joined with us in the panelist link. We acknowledge their presence. Due to want of time, we just go ahead with the CME program. Dr. Dana, please introduce Dr. Dana.
Yeah. So first talk by Dr. Tanu Singhal. So I need not introduce her. She is a well-known person in pediatric infectious diseases. I extremely thank from my bottom of heart for immediately accepting our invitation. In spite of her busy schedule, she accepted. She is currently the consultant pediatric infectious diseases co-11 Triboy Ambani Hospital. Over to you, ma'am.
Hello, can you hear me?
Yes,
Yeah.
ma'am.
Yeah. So I would like to thank Dr. Dhanlakshmi, Dr. Narmada, Dr. Janani for inviting me. And it's once you get these invites that you actually sit and read the topic. So actually it benefits you more than the others. So thank you for giving me this opportunity. And with that, I would like to share my screen. Okay, so can you see it now?
Yeah, but you can make it in the slideshow. It's correct.
Yeah. Okay. So today I'm going to be talking about what is new on diagnosis and management of TB. And this lecture basically assumes that you know what is the current standard of care and we are building on top of that. And I think revision of what is current will also happen in the panel discussion that follows later. So this is just some statistics that, we have about 10 million new cases of TB every year in the world, and 25% of that burden is in India. Pediatric TB contributes to 10% of the global burden. That means there are about 1 million cases. And interestingly, the mortality in pediatric TB is 20%. So that means 200,000 children die every year because of TB. And mostly these are children who are not diagnosed. Because there is further data to say that only half of pediatric TB actually gets diagnosed. And we as pediatricians know why this happens. Because the symptoms are quite non-specific. Then the chest X-ray is again difficult to interpret, not like adult TB where you see a cavity. You have difficulty in accessing samples. And then pediatric TB is a paucibacillary disease. So it's very difficult to prove the diagnosis microbiologically. So I think when we talk about the gaps, so there is a diagnostic gap which is bigger than the treatment gap. And in today's lecture, I'm going to talk about the diagnostic gap and how that can be bridged with what is happening new. And then we'll talk about what are the new treatments which are there on the horizon for both drug-sensitive, drug-resistant TB. And finally, I'll finish off with what is happening in the field of prevention. Now, we all know that when we diagnose TB, there are many things which help us in the diagnosis. So clinical symptoms is the entry criteria and a contact history. Then usually we follow that up with imaging, and that imaging depends on what is the site of TB that we are suspecting. So it may be a chest X-ray, it may be a sonography, it may be a CT scan, or it may be an MRI. Especially in CNS TB, we like to do MRIs if they are available. Then there is not much happening in serology. In fact, earlier, maybe 10, 20 years earlier, people were doing TB, IgM, IgG, ELISA, which have now been completely given up. And then after we do the initial symptoms, signs, and imaging, then we try and prove the diagnosis microbiologically, and we obtain the appropriate specimen. And this specimen is then subject to cytology or histopathology. If it's a biopsy or if an FNAC, we do a AFB stain. We also do molecular tests like GeneXpert or TrueNat. We send it off for midget culture. And then there is also this section on how do we diagnose latent infection. So today, in today's lecture, I'm going to basically focus on what new is happening in some of these areas, which are highlighted on the screen. Now, let us look at imaging. Now, we all know that chest X-ray is the first investigation which we do, especially if we are suspecting intrathoracic TB. But the problem with chest X-ray is that, it does not pick up mediastinal adenopathy well, which is the commonest manifestation of pediatric TB, because we have the other things in the mediastinum which hide it. And it is, sometimes you think there is mediastinal adenopathy. When you do a CT, it is not there. Or if the chest X-ray is normal and you do a CT, you pick up adenopathy. So that is a major limitation. Then these children, often if they're small, they don't stand still. They don't hold their breaths. That is a problem in the quality of the X-ray. And also there is a lot of inter-observer variation. So one person may call a chest X-ray normal and the other person may call it abnormal. And in fact, studies have shown that even pediatric radiologists may not be very accurate in reporting chest X-rays. So what is happening here is that now we have more and more digital X-rays, which are which have better quality. And in fact, now various artificial intelligence-based algorithms have been developed to pick up abnormalities. And this has especially happened more after the COVID times. In fact, if you look at the latest WHO guidelines for diagnosis of TB, AI-based algorithms have been included in the diagnostic criteria for adult TB, but not for pediatric TB yet. But I think in the next few years, we will probably have X-rays which will be read by AI, and maybe we will get better or more accurate reports then. Now, coming to sonography, we all use ultrasounds a lot, especially if we are looking at lymph node disease in the neck, or pleural effusions, or abdominal tuberculosis. Ultrasound is excellent because it does not involve any radiation exposure. But the problem with ultrasound is that it is observer dependent. And one of the common sites of pediatric TB is the lung, and you can't use ultrasound for diagnosis of lung TB because the air blocks the ultrasound waves. But now, like point of care ultrasound is there for diagnosis of various problems in the ICU, focus has also come in for using the supraclavicular or the left parasternal approach to pick up mediastinal adenopathy. And in fact, there is now a systematic review which tells us that the sensitivity of ultrasound to pick up these nodes can vary anywhere from 15 to 85%. There was one study in which 67% of the children who had normal X-rays had an ultrasound which picked up adenopathy. So this is something which is really going to come up later. And in fact, at our hospital, we are encouraging our radiologists to start doing ultrasounds using the supraclavicular window to pick up mediastinal adenopathy. Then when we talk of CT scan, we immediately think, oh, it's costly. Then there is the radiation exposure. And as doctors, we are worried about it. And some of the well-educated parents are more worried. Then you need to often sedate the child. And another problem with the CT scan is that if you pick up nodes in the mediastinum, you don't know whether those nodes are because of active disease or is it because of latent infection. So what is happening in CT scan imaging? One is that there are now new CT machines which have come in, which have multi-detector, dual energy, emerging photon counting detectors. Don't ask me what this all means, but this basically means advanced machines which reduce imaging time, and they obviate the need for breath holding, and they reduce the radiation exposure so much so that now earlier when one CT would be equivalent to 20 or 30 X-rays, now with these new techniques, the radiation exposure due to CT would be equivalent to 6 X-rays or 3 sets. And AI-based algorithms have also been developed to interpret CT scans. And then finally for MRI, we know that MRI is the preferred imaging for spine and brain TB, but the limitations of MRI are that, again, it is expensive. You need even longer time than the CT scan for imaging. Then you need to sedate the child, and there is the problem of claustrophobia. And MRI has not really been evaluated for diagnosis of intrathoracic disease. But now there are new MRI protocols that have been developed which reduce the time. And in fact, now studies say that MRI is actually similar to contrast CT for node or pleural disease, and it is better than unenhanced CT. So now sometimes, you have children who have renal impairment where you can't do a contrast CT. So in that situation, an MRI may be better as compared to a unenhanced CT. And there is another point that, with MRI techniques, you can now even distinguish between reactive nodes and TB nodes because of the T2 signal abnormalities which are seen. So this is just to tell you that a lot of things are happening in imaging, which is actually, I feel, a very, very important modality for diagnosis of pediatric TB. Because remember, 50% of pediatric TB will not be microbiologically confirmed. So all you have is history and imaging findings based on which you will start therapy. Here, I would like to talk a little bit about the CT scan. Now, if you look at the guidelines from the NTEP, they always actually frown upon CT scan because, I already said radiation, cause, sedation, etc. But in practice, it's a most useful second-line investigation in PUO. And you know that many children with TB actually present with just fever going on for 1 or 2 weeks, and they don't have any cough or any respiratory manifestation. They often have normal X-rays. And many times these children are subject to repeated CBCs, CRPs, Vidal, etc., and with no yield. But here I would say that beyond the CBC, CRP, blood culture, ultrasound, X-ray, the next investigation which you should do in a PUO should be a CT scan, because often you will pick up necrotic mediastinal lymph nodes. And this was one study which we published quite some time ago, where we looked at 50 children with PUO, and we found that 50% of these PUOs were actually due to tuberculosis, and the diagnosis was mainly established by a CT scan. Therefore, you have to carefully select cases where you would want to do a CT. And for example, if you have a patient who has an X-ray abnormality, you have given antibiotics, the X-ray is not better, you do a gastric lavage, and yet it is negative. Then if you do a scan and you pick up necrotic nodes, or you pick up some other abnormality, then you are more sure that you are probably dealing with tuberculosis. However, at the same time, I would like to caution that, we shouldn't jump and do CT scans in all non-pneumonias, because you see that commonly happening in clinical practice. And you must remember that all kinds of pneumonias, whether they are bacterial or atypical, will have some nodes in the mediastinum. And therefore, you have to select cases carefully. But then I find that a scan is actually a very, very useful investigation in diagnosis of intrathoracic TB. Now, moving on to another test which is come up is the lipoarabinomannan antigen test. So there is a strong need for a serologic point of care test to diagnose TB. And in fact, there are many times with parents ask me that, doctor, is there any test which we can do from the blood which will confirm TB, because we don't want to do these biopsies or gastric lavage. And actually, many times people think that, is it the IGRA? But remember, IGRA is not a test to diagnose TB disease. It's a test to diagnose TB infection. So we need a serologic test which can be done in either blood or urine. And one such antigen which is being evaluated is the lipoarabinomannan antigen, which is a part of the mycobacterial cell envelope that is excreted in urine in patients with active TB. But the levels are high mainly in those who have HIV, maybe because the mycobacterial load is high, or there is glomerular dysfunction because of which the clearance of the antigen does not happen. And there are tests which are available, which are point of care card tests like ALER-LAM and Fuji-LAM, and also ELISA. And studies have shown that actually the card tests are more sensitive than the ELISA, and the sensitivity is high in HIV-infected children. So as you can see, that in HIV-infected, your sensitivity can be between 50 to 75%, whereas in HIV uninfected people, the sensitivity is lower. But if you look at the Fuji-LAM test, even in 50% of HIV uninfected children, your test can be positive, and the specificity is quite high. So that means that if you do this test and the test is positive in the urine, then you are fairly certain that you're dealing with active TB if your clinical symptoms and X-rays are fitting in. But it is mainly a rule-in test. It's not a rule-out test. So the current WHO guidelines actually say that if you have an HIV-infected child who is either admitted to the hospital or who is admitted to the hospital and is either having signs and symptoms of TB or is seriously ill, or even if the child has no signs and symptoms of TB but has a CD4 count of less than 200, you should do this test. And in adult studies have shown that doing this test actually reduces mortality. So I think this is a very useful test, especially for HIV-infected children, mainly in the inpatient setting, but also in the outpatient setting. But the problem is that this test is not yet commercially available in India. I think there is a move to get the test available, and in that case, then we would probably be able to use it. Remember, it's a rule-in test and not a rule-out test. Now, moving from LAM, let us talk about the molecular tests. Now, we know that we know expert MTB and we know TrueNat. And this expert MTB gives you a report saying that, what is the load detected. We say either very low, low, medium, high, very high. And these tests actually have sensitivities which are varying from 10 to 80% for pulmonary and extrapulmonary disease. That means when you compare them to a gold standard of culture. And so, for example, if you have a primary complex, and then the sensitivity in the gastric lavage will be just 30%. But if you have cavitary disease, it can be even 70, 80%. The sensitivity is quite low if you have pleural, pericardial or peritoneal disease. So one thing is that the sensitivity is good, but it is not good enough. And the second problem is with expert is that, you can incorrectly diagnose rifampicin resistance. So if your load detected is very low, then if your test says that rifampicin is resistant, you have to reconfirm that, because sometimes it can call a sensitive isolate resistant, but it will not do the other way, that it will not call a resistant isolate sensitive. So these are some of the limitations of these tests, and that is why there is always a scope for improvement of molecular tests. And the test which I would first like to talk about is Expert MTB RIF Ultra. I think many of us are already using this test because it's available in private labs. And so this test actually has two targets for detection of MTB and a larger chamber. And that is why the sensitivity is actually higher. They say that it detects 16 bacilli per mil compared to 131 by Expert. And therefore, the report actually has an extra call, which is called as trace. So that is there. And those are the trace results are those which are actually positive by Ultra. But if you actually would do an Expert, it would be negative. Now, the overall sensitivity of the Ultra is about 10% higher than the GeneXpert. And this test is particularly useful in the CSF. So if you have a patient with TB meningitis, which is a very serious disease, then you should make an effort of sending this test, even if it means sending it to a private lab, because the pickup will be more as compared to the normal Expert, which is about almost like a 30% increment. The other specificity of this is lower than the Expert. Why? Because, when it is detecting very small number of bacteria, then sometimes, even if you have these bacteria which are present because of latent infection in your tissues, it will pick them up. And therefore, the specificity is lower. And it performs well for diagnosis of rifampicin resistance. And another advantage of the Ultra is that I told you earlier that, if your load detected is very low, your Expert will call a sensitive isolate resistant. But in Ultra, that doesn't happen. So it will call it indeterminate. So that means indeterminate means that resistance cannot be judged, whether it is sensitive or resistant, but at least you won't be misled. And it is approved by the WHO, but not by the National Tuberculosis Elimination Program, because they basically have issues with the specificity of the test. But for pediatric TB, I think it is a very important test, because we know pediatric TB is paucibacillary, and therefore the enhanced sensitivity is good. But I would like to say that when you send this test, you should interpret the trace call very carefully. And I would just like to present two cases where highlighting this issue with the Ultra. So this is a case which I just saw about a month ago. This is a 3-year-old male who had fever for 3 days. And after that, sudden onset weakness of 4 limbs. Now, when this child was admitted to an ICU in another nursing home, they did an MRI first and which showed some meningeal enhancement. And when they did a CSF, it showed 50 cells, protein was mildly elevated and sugar was normal. And they also sent the CSF for expert. Now, here somebody would argue that was there actually a need to send expert here, because the clinical picture is not like TBM. You rarely have TB meningitis coming with such an acute history and weakness of all 4 limbs. But the expert ultra came positive, trace positive, and then the treatment was started with anti-TB drugs and steroids, and the child got better. But then the parents came to me for a second opinion. And when I looked at the history, I found that the history is not like TBM. The duration was very short. The child was not irritable, was not vomiting and on examination, all the deep tendon reflexes were absent. So I thought that looks more like a Guillain-Barré syndrome. And when we did an EMG and NCV, it showed a demyelinating neuropathy. So with that, I stopped the AKT and steroids and just continued physiotherapy, and the child is well on follow-up. So in this case, there are 2 errors. One is that you sent a TB test, which was actually not indicated because the presentation is not like TB. And second, when a report came positive, then it was not interpreted in context of the case. So that is the issue with the ultra, that sometimes you can get it false positive, like in this patient. And this is another paper which we published some time ago. And this was actually a case, a 15-year-old child who had presented with history of spondylodiscitis. You can see the MRI showing this spondylitis. And he had multiple lung lesions. And this child's biopsy from the spine was inconclusive. He had received antibiotics. He received TB treatment. And when he came to our hospital, a bronchoscopic lavage was done. And the bronchoscopic lavage was positive for ultra. And at that time, and the RIF resistance was indeterminate because it was trace positive. So MDR treatment was started. But actually, this child had Hodgkin's when we finally did a biopsy from one of the nodes. So this expert ultra in the bronchoscopic lavage was actually a red herring, and it misled and it delayed the diagnosis of Hodgkin's disease. So while expert ultra is a very good test and it has better sensitivity, and 98 times out of 100, it will give you the correct diagnosis, but you must remember about its interpretation, especially if other things are not fitting in with TB. Now we come to expert XDR. Now you already know about the line probe assays, and you know that your GeneXpert will only tell you about rifampicin resistance. And for knowing resistance to INH, fluoroquinolones, aminoglycosides, you have the line probe assay. And you have line probe assay 1, which tells you about INH resistance, and line probe assay 2, which tells you about the others. And this line probe assay is done from smear positive or culture positive samples. In pediatrics, because most of the times the smear is negative, you do it from the culture. Now you have this expert XDR, which is basically a cartridge-based test that can be run on the same expert machine. So line probe assay actually needs technical expertise, whereas expert XDR is just like the fill it, shut it, forget it test. And this test is done from cultures and smear positive samples. And in this test, you will simultaneously get all the information which you would get from LPA 1 and 2. So it will tell you about INH resistance. It will tell you if it is detected, whether it is due to INH-A or CATG gene. It will tell you about aminoglycoside resistance and also ethionamide resistance, because ethionamide resistance is actually an inferred resistance, because if your CATG is absent, then they say resistance is not detected. So what is the advantage of XDR over LPA 1 and 2? That 1, it is a point of care test and it gives you a quick result. And the cost of the XDR is also, the expert XDR is also the same as LPA 1 and 2 if you do it in the private sector. Another advantage of the XDR is that it tells you about fluoroquinolone and INH resistance together, because suppose you do a LPA1 and you find that INH is resistant, then you have to do an LPA2 to know if the quinolones are sensitive or not, because you will be using quinolones in treatment. And this test will give you the results together. The test is not approved by our National Tuberculosis Program. So that is why if you are dealing with a child with MDR-TB, then you should ask for the LPA 1 and 2, not expert XDR, because they will not take this result of XDR into their protocol or in their treatment. They will again ask for an LPA 1 and 2. And then I'm not going to spend too much time talking about the other molecular tests which are not in the commercial domain yet. Like you have TB LAMP, which is for low resource settings. Then you have whole genome sequencing, which is done, which tells you about resistance to all the anti-TB drugs, including other drugs like linezolid, clofazimine, bedaquiline, delaminid. And you have next generation sequencing. There is also this test called pyrosequencing, which we do in Mumbai because Hinduja offers this test, because this test actually can detect the MTB directly from the clinical sample, and it will tell you whether it is RIF resistant or not, whether it is INH resistant or not, and whether it is quinolone resistant or not. So, so that is an advantage of this test, because you know that your LPA 1 and 2 cannot be run from smear negative samples, and neither can your XDR be run on smear negative samples. So this test can be run on smear negative samples also. Another advantage of the test is that suppose you have done an expert or expert ultra and your RIF resistance comes as indeterminate, then you can ask for pyrosequencing, because that may reconcile whether that RIF is really sensitive or resistant. So this is one paper which was published by Dr. Rodriguez, from Hinduja Hospital, where they had 100 patients with TB, meningitis, probable, possible, etc. And here they did basically midget culture, they did GeneXpert, not expert ultra, and they did pyrosequencing. And they found that the sensitivity of pyrosequencing and negative predictive value to the case definition of TBM was 98%. So that means the test was very sensitive, and the test was also had a very high negative predictive value. That means if your test is negative, then you might think you might actually rule out TB meningitis. But the test is not available in many research labs. It is not approved by the NTEP, and it is not approved by the WHO. But this is just to tell the audience that suppose you have a difficult case of maybe meningitis, a chronic meningitis, where all your tests are coming negative, this is a test which you could ask for and which may help you in making a diagnosis. So we have talked about the tests, but is there anything happening in terms of specimen collection? So we have this gastric lavage and induced sputum. You all know these techniques, and the sensitivity is 60 to 70% compared to culture. But the problem with these tests is that one is that they are unpleasant. Many children don't cooperate for gastric lavage. Many parents don't want it to be done. And then there is risk of aerosol generation for induced sputum. So you have this tool for molecular tests. So again, it is based on the same principle that it detects the mycobacteria which is swallowed by the child. And you need to process the stool in a different way, and because there are PCR inhibitors in stool. And then you need to run the test on the expert machine or the expert ultra machine, and the sensitivity is lower than the gastric lavage or induced sputum, 10% lower. And its sensitivity is higher in older children and cavitary disease. Now, this test is this specimen is endorsed by the WHO, but not by our program. Why? Because one is that there is a special processing needed. Then there is lower sensitivity. That means if your stool expert comes negative, then you have to do a gastric lavage, and that will actually double the cost of the test. And also because in many government centers, you have TrueNat machines and you not have the GeneXpert machine, and there's not much data about TrueNat on stool. So that is why there are very, very few private labs which are actually offering stool, but it is a very convenient sample, and if your test is positive, then you know that your child has TB and you don't have to go around doing gastric lavage, etc. Then there is nasopharyngeal aspirate, where you just don't give a bronchodilator, don't give hypertonic saline, but just put a suction catheter in the nasopharynx and collect the sample. Now, again, its sensitivity is 10% lower than the induced sputum. And then you have other tests, like just an oral swab, you have the entro string test. And then there is this bioaerosol sampling, which I found interesting, in which the child actually wears a special type of N95 mask for 10 minutes, where he coughs or reads or shouts. And then you remove the mask and you process the membrane inside the mask by a different PCR, not the GeneXpert, and good sensitivity. So this is also a new test which has come up. And then I talked about latent infection. Why is there a need for new tests for latent infection? Because there's a push of TB preventive therapy to all household contacts with bacteriologically confirmed TB. Now, we all know the tuberculin skin test. But the problem with the TST is that one, the PPD-RT23 between 80 is not available. There is a shortage. Then it is needs 2 visits. And you can have a positive test due to past BCG also. So that means you have the IGRA, which have been developed, that is the interferon gamma release assays, because it's a single visit test and it does not, the BCG interference is not there. NTM interference is not there. But the issue is that it is expensive and you have a lot of indeterminate results coming in your IGRA. So that is why this CTB test has been developed, in which you use the same antigens, like is the ESAT6 and CFP10 antigens, which are used for the IGRA. But in IGRA, you put these, you expose the blood to these antigens. Here you inject these antigens like you do a TST, and you actually use a smaller cutoff of 5 millimeter as a positive test. And there have been several trials which have been done in various populations, and they have found that the sensitivity and specificity of the CTB test is same as your MAN2 or your IGRA. And therefore, this test is now, the antigen required for the test is being produced by Serum Institute of India, and it has been adopted by the National Tuberculosis Elimination Program. And soon, I think it will be available in the commercial domain, and we will be doing this test rather than the TST. So that was what I wanted to talk about diagnosis. And very quickly, I would like to again discuss what is happening in treatment. Now, we all know that the standard of care is 2 months of 4 drugs and then 4 months of 3 drugs. And we know that we have to extend the continuation phase in patients with CNS or bone disease. So the problem with this is that, you know, your duration of therapy is quite long and compliance is an issue. So that is why the shorter regimens are being looked at. And the most famous trial here is the SHINE trial. This SHINE trial actually recruited children between 3 months to 12 years who had probable non-severe TB. That means either they had lymph node TB, or they had a pleural effusion, or they had pulmonary disease which was localized to one lobe without cavitation. So basically, children who would have paucibacillary disease, and they randomized them into 2 groups. In one group, they gave 6 months therapy. In the other group, they gave 4 months therapy. And then they looked at the outcomes at the end of 6 months or over the next 1 year. And of this population, we must remember that only 14% were bacteriologically confirmed. And they found that the outcomes were same in both the groups. So even the shorter regime actually did as well as the long regime. And therefore, this was endorsed by the WHO. So actually, you know, I was just 3 days ago, I had a child, you know, who we diagnosed as TB because he had necrotic mediastinal lymph nodes. And I told the mom that the child will need 6 months of therapy. So she turned back and asked, but doctor, isn't there a 4 months regime now? That's what she asked me. Can we not give it to my child? Because I don't want to give him drugs for 6 months. So is this SHINE trial applicable in the Indian setting? Because it has the potential to reduce cost and improve adherence. But so far, the program has not adopted it, because one thing they say is that it will be very difficult to differentiate severe versus non-severe TB in the field, because many of these cases are handled by the medical officers. Then X-rays are poor quality. It is difficult to interpret whether the disease is in one lobe or 2 lobes. And also, this is just one trial, and the number of children from India included in this trial were just 149. So maybe there will be a pilot in future. And I must say that we in the private practice should not use this regime till it is endorsed by NTEP, because it will cause confusion. Many of the children whom we treat are also followed up by the program. And if we tell the parents to stop the drugs after 4 months, and then the program will tell them to continue for 6 months, there will be a discordance. So we should continue 6 months treatment, but you should know that there is a regime like this. And I think the only practical importance is that the rare cases that if you have a child who had non-severe TB, who stopped his treatment after 4 months on his own, and then he comes back to you, then you may not decide to restart the therapy, because you know that for non-severe TB, 4 months may be enough. So I think at the moment, that is the only applicability that I can see. And there is another shortened regime, which is rifapentine and moxiflox based. So you must know about rifapentine, because this drug is coming in both for treatment and for prevention. So rifapentine is a rifamycin like rifampicin and rifabutin, but the advantage is that has long duration of action because it remains in the blood for a long time. And there was this multi-center trial which looked at TB patients more than 12 years. So SHINE trial was till 12 years. This is above 12 years, and where 3 regimes were compared. In the first group, you had isoniazid, rifapentine, pyrazinamide, and moxifloxacin for 8 weeks. And then we had all 3 drugs without pyrazinamide for 9 weeks. In the second group, you had rifapentine, isoniazid, pyrazinamide, but you didn't have moxi, you had ethambutol. And the third group, you had the standard 6 months regime. So you had 4 months versus 6 months. And what they found in this trial is that the regime, which included both rifapentine and moxi, was non-inferior to the 6 months regime. But the regime which included rifapentine and ethambutol for 4 months was not non-inferior. So therefore, this is another drug regime, shortened regime for children above 12 years and weighing more than 40 kg. But the issue with this regime is that there's no FDC available, and rifapentine actually should be taken with meals. And again, a problem in the Indian setting for drug-sensitive TB is that if you start using moxi for drug-sensitive TB, we know that there's a big burden of drug-resistant TB in our country, and we might be compromising moxi therefore. So as of now, this regime has not been adopted, and we should also not use this regime in our practice, and we can't use it also because rifapentine is not available for us to buy in the market. We all have treated with treated TBM, and we have had issues with TBM treatment because even with the 12 months therapy, our patients don't do well. Many of them die. Many of them have neurologic sequelae. So there is this Cape Town regime from South Africa, which is a 6-month regime, which includes isoniazid, rifampicin, pyrazinamide, and ethionamide. And why they've chosen ethionamide is because this drug has excellent CNS levels. And we know ethambutol has actually very poor levels in the brain, but we continue to use ethambutol because there's nothing else to use. And there are no trials which have compared this regime to our standard regime, but there is a systematic review which looked at this regime, comparing it to the standard regime, and they found that mortality, treatment success, and neurologic sequelae were all much better with this regime. So again, this is something to look at, but it's not been adopted yet, but maybe in future. The biggest changes have actually happened in drug-resistant TB management. And, because of want of time, I'm not really going to go into the details much, but you must understand that there is a lot of change. Like earlier, you were using a lot of aminoglycosides, so now we are not using them. Then there are new drugs which have come in like bedaquiline and delaminate, and there is reclassification of the drugs into group A and B drugs, which are the most important drugs for DR-TB, and these include bedaquiline, the quinolones, linezolid, cycloserine, and clofazimine. And so this gives me an opportunity to tell you that linezolid is a very, very important drug for MDR and XDR-TB, and therefore we have to use it in caution in other kinds of bacterial infections in our day-to-day practice. So there are so many regimes going on, but in the Indian context, there are 2 regimes which are used. One is the long oral regime for most of the cases of drug-resistant TB, where you use bedaquiline with quinolone, with linezolid, with cycloserine and clofazimine for 6 months. And after that, you just use the quinolone, half-dose linezolid, clofazimine, and cycloserine for 12 to 18 months. And in children below the age of 5 years, bedaquiline is replaced by an aminoglycoside. And then there is a shorter regime also, but I won't discuss that because there are very few children who would satisfy criteria for the shorter regime. And while the WHO recommends that you can use bedaquiline and delaminate in children below 5 years, our program has still not given that approval, but off-label, we are using bedaquiline and delaminate in children below 5 years, like in older children. This, I think, is most important for our viewers about what is the update in prevention. Now, you know that earlier we used to give TB preventive treatment only to children below 6 years who were household contacts of bacteriologically confirmed pulmonary TB. But now the target population has changed, where the government guidelines say that once you rule out active TB in the contacts, then For all children below 6 years, you have to give them TB preventive treatment. And or those who are above 6 years of age, you should do a test for latent infection, which is either a IGRA or a MAN2 or a CTB test. And if it is positive, then offer them preventive therapy. If it is negative, you may not give them preventive therapy. And if the test is not available, you can still offer them preventive therapy. And why is this change? Because we want to reduce the pool of active TB. However, the issue here is that in a high burden country like India, suppose you have been exposed to a person with TB, household contact, and you take preventive treatment, you can get re-exposed because TB is there everywhere. So that's an issue here. And we all know that there is a 6 months of isoniazid and pyridoxine that we give for prevention. But again, the compliance with this is poor because it's prolonged treatment. So there are alternative regimes which are recommended in other countries, like 4 months of rifampicin alone or 3 months of INH and rifampicin. But these are not approved by our program. But what is coming in quickly is 12 weekly doses of high-dose INH and rifampicin in children above 2 years. So that means you just have to give weekly for 12 weeks and your TB preventive therapy is done. And so it is so easy to do, and basically it is non-inferior to the 6-month regime. So I think soon this will be rolled out throughout the country. And earlier we used to say that if you have a household person with MDR-TB, then you can't offer TB preventive treatment. But now in the new guidelines, you can, if the contact is having drug quinolone susceptible MDR-TB, then you can give 6 months of levofloxacin to your patient or the child who is in contact with the adult. So finally, I would like to conclude by saying that there are many advances in diagnostics, like in imaging, in alternative specimen collection methods, better molecular tests like Expert Ultra. We have the CTB test. We have urine lamp for HIV-infected children. There are advances in treatment like shorter regimes for drug-sensitive TB and new regimes for DR-TB. And there are advances in prevention. Basically, that everybody who is exposed to a bacteriologically confirmed pulmonary TB should be evaluated for chemoprophylaxis, and you have the new regime coming in. And with that, I would like to stop and just tell you that, you know, IJP, Indian Journal of Pediatrics, has just come out with a new symposium which talks about all the updates which have happened, which I've discussed in my lecture. And these are available, full text online is available on the internet. So please do read these papers and, update yourself. Thank you so much.
Hello. Thank you, ma'am. Thank you so much for the excellent updates. Ma'am, we have a few questions in the chat box, ma'am.
Sure.
Yeah. So the first question is whether CT or FDG PET for PU. So I think CT, plain CT is enough.
Yeah, so FDG PET is really used in adults because malignancy is an important differential. We don't have that commonly in children. So I think CT with SOS contrast is good enough for most cases of PU.
Okay. So why not GeneXpert Ultra is not yet accepted in NTP?
I discussed that it's less specific. So the government is worried about picking up false positive. And second is that it can only be done on GeneXpert machine. And there are so many TrueNAT machines also. So I think those are the issues with the Expert Ultra.
And recently we had a child with neuromyelitis, I think Janani ma'am's case only. So we did a brain biopsy, and the brain biopsy ultra was highly positive. But fortunately it grew Burkholderia pseudomyelin. So always.
Yeah, so that is the issue. Like I showed those 2 cases where we had an alternative diagnosis, but your ultra was positive, because what happens is that when anybody gets infected with TB, the bacteria travel from the lung to the blood and go to various organs, and they lie latent. And sometimes, you can pick these up. So, I mean, when you have precious samples like a biopsy, you will send it for everything. Like you are not going to do sequential testing that if my culture comes negative, then I will do it. So you will do a aerobic culture, you will do fungal culture, you will do expert, you will do midget culture. But then when you get your results back, then you have to look at them carefully. You have to look at the histopath. Now in your patient, if the histopath showed just acute suppurative infection and didn't show any granulomas, then you would think that this is
Then we
a...
retrospectively reviewed the MRI, CSF, everything in favor of neuromyelidosis. But initially we were a little hesitant to stop ATT. So we gave for 3 weeks and then stopped.
Yeah, and sometimes, rarely you may also have co-infection. So you could have two things. That is less common. Mostly you have a single diagnosis, but you have to interpret in light of everything.
Ma'am, for RGG sample, you prefer expert or ultra?
What is RGG? What did you
Resting
say?
acid juice.
No, I mean ultra. I mean, if you're in the private sector, you would do ultra because, as I said, the sensitivity is higher.
But most of the times we are
For
getting this.
bronchoscopy, for bronchoscopic, we are doing expert and we are not doing ultra because it has the potential to pick up latent bacteria. But for gastric lavage, if you have the facility, you should do ultra because I showed you the sensitivity of ultra in gastric lavage is about 10% higher than the expert.
Okay. Then what is the cost of pyrosequencing?
It's about 5,000-6,000. Okay, so that is the cost. So, I mean, if you have a sample where you're really stuck and you want to look at it, then you can actually send it to Hinduja Hospital. They do it.
Okay. And in the SHINE trial, whatever you have mentioned, short-term regimen for TB, what was the duration of long-term follow-up?
I think they had a 12 to 24 months follow-up. They had that much follow-up and they found that because what they were looking at, their primary outcome was also restarting of TB treatment, change of TB treatment, extension of TB treatment. These things they were looking at. So obviously they had a follow-up which was long enough to know that relapse and all didn't happen.
Okay. Any other questions? Narmada? Muted.
We can move on, Dr. Dana, because we're pretty late for the panel. Yeah. Thank you so much, ma'am.
Tanu, it was an excellent session.
Very
Thank
excellent
you.
session, ma'am. Thank you so much.
Thank you.
I think I overshot my time by 5-10 minutes. I'm sorry.
That's okay. That's
It's
okay.
okay, ma'am. It's nice to hear.
All useful information. No
job
problem.
easier.
Thank you, ma'am.
So we'll just proceed with the panel discussion.
Yeah. So now we'll move on to the next part of our CME. So now we have panel discussion moderated by Dr. Vidya Krishna. She is currently the consultant pediatric infectious diseases at Apollo Children's Hospital and ably guided by Dr. Janvi Shankar. She is all of you, I need not introduce her. She is a past chairperson of PIDA and currently she is the medical director of Kanchi Kamakodi Child Trust Hospital and ably supported by Dr. Vaishnavi. She is a consultant pediatric infectious diseases at Rainbow Children's Hospital, Bangalore. And Dr. Abhinesh, he is a consultant pulmonologist practicing in Nagarkoil. So I'll hand over the mic to Dr. Vidya.
There's a background noise. Are you all able to hear?
Yeah, I think
Mute all the others.
It's Dr.
I think
Dana.
it was Dr. Dana's, ma'am.
Okay. Yeah.
Shall I start?
Yeah, please.
Yeah. Good evening, everybody. So I think following Dr. Tanu's lecture, it's going to be slightly more easier to follow the panel. We tried and kept very simple scenarios and cases that we see in everyday practice. I saw a lot of questions in the chat box. I think we will be answering all the questions that you have on this panel. So without much further ado, I'll start the first case. So this is a 4-year-old boy who comes with a history of episodic cough for the last 5 months. There's no fever, no weight loss, no contact with TB. Chest X-ray and MAN2 is requested. I don't know what they were trying to look for, but it was done. And now my first question is to Dr. Vaishnavi. So what symptoms in children should actually prompt TB workup? So here you have a child who's come to you with an episodic cough for last 5 months. So what do you think is going on clinically? And do you think this necessitates a TB workup?
Hi, good evening all. So generally symptoms in children which should prompt a TB workup will be a persistent cough beyond 2 weeks, persistent fever, weight loss, which is usually more than 5% of the body weight in the last 3 months if the child has lost, or child is not gaining weight, or there is history of contact with a person who has TB in the last 2 years. So these are usually the symptoms that we see in children.
So I think the crux of the thing that we're trying to say is try and look for persistent cough rather than recurrent
Episodic
symptoms.
cough, correct.
Child might have recurrent URTIs, recurrent LRTIs, recurrent Vs. So there's always an asymptomatic period in those illnesses. So if we try and start evaluating all those kids for TB, then we are going to be landing up with a lot of problems. So that is an important pitfall that happens in the thing. So again, evaluating MAN2 and IGRA, we have talked about this forever and it never ends. The story never ends. So where do we place MAN2 or IGRA in pediatric TB case management? I would ask Dr. Janani to please highlight on that.
Yeah, I think MAN2 is IGRA, of course, only when you are going to start a biological for a child, immunosuppressed child. Otherwise, IGRA we don't use regularly in routine practice. MAN2 again, for a child, I mean, it only tells latent infection, so it does not, it can be used as a corroboratory evidence when you have a child with, when you want to really start tuberculosis treatment. It's just a T-cell mediated, so it just serves as an additional information. But MAN2 negative does not rule out the disease. And MAN2 positive does not always mean that there is a disease. So you'll have to correlate it with the clinical context. And with the 2TU MAN2 that is available, I think it's not available in all the places. Still, some places use 5TU. So I think we'll have to and the method and everything, correlate it with the clinical situation.
Yeah. So basically, MAN2, IGRA is the TB gold test. Somebody had asked in the chat. So the TB gold test is IGRA, interferon gamma release assay. So both these tests are tests of latent TB. So in the current day and age, we don't want to rely on them to make a TB case diagnosis. These are tests used to diagnose latent infection and to decide on prophylaxis. Yes. Okay. So we'll go back to our case. So this child who had a clinical diagnosis, who had this recurrent cough, the clinician decides that it is asthma. He wants to start inhaled corticosteroids. But now because the MAN2 is done, it is positive. It is 12 into 10 millimeters positive and X-ray is normal. So in this scenario, I can tell you that all the 4 options that I have given can happen, like depending on who the child needs. I'm sorry. So one doctor will prescribe ICS and just follow up the child. A doctor B will order IGRA and IGRA will become negative and will not give prophylaxis. A doctor C will prescribe 3HR. And a doctor D is now worried that there is a MAN2 positivity. Am I missing a pulmonary TB? And he might order a CT chest. So all these things are what we see in practice. So I would probably request Dr. Abhinesh to comment. What do you think is the right answer in this?
Yes, madam. As the clinical diagnosis is a visa or asthma pattern of symptoms, we'll start the child on ICS and follow up the child and see whether the symptoms settling. As far as the MAN2 is concerned, it is not indicated and there is no household contact, so there is no need for TB preventive therapy.
So what we're trying to say is, if you're clinically, you never thought of TB in the first place, if you have a MAN2 positivity and you don't have any recent household contact of TB, then you can safely ignore that and don't chase it. Try and look for active TB or try and do tests for active TB and all those things. Just ignore it. Go by your clinical diagnosis. Here, your diagnosis is asthma. Just start inhaled corticosteroids, and anyway, a child is going to be on a follow-up. Follow up the child. Okay, so I think with that, we sort of will move on to the next case. So this is again a 7-year-old girl. So the father is now newly diagnosed with a smear-positive pulmonary TB. So my first question to Dr. Vaishnavi is, so we heard a lot about the newer guidelines from Dr. Tanu. So what do you want to do with this girl as per the newer recommendations?
Yes. So when there is a history of contact with a person with tuberculosis, first we need to see if the child is symptomatic or not symptomatic. If the child is symptomatic, then it is important that we have to look for active TB disease. So we'll have to do an X-ray, we will have to do a sputum or a fasting gastric aspirate to look for TB, especially if there is symptoms in the child. Because we should not blindly start prophylaxis. The child may actually have active tuberculosis disease. If the child is not symptomatic, then we can get by just screening the child, maybe with an X-ray, since it's non-invasive. We can offer a MAN2, and we should definitely give prophylaxis. So now prophylaxis is recommended for all household contacts, because they found that actually prevalence of the children who had contact with a person with TB was 20%, and over the years it can go up to 40% in the next like 6 months, 9 months, etc. So prophylaxis should be offered to all children who have contact with TB.
I think I would ask Dr. Abhinesh and Dr. Janani ma'am, anything that, how is it different in younger children and anything else? So I'm just going to show you one NTP slide so that it's easy for all to understand when they are talking. So this is what the guidelines recommend. So under 5 years and above 5 years. Dr. Abhinesh, if you can just Elucidate on that.
In under 6 years of age, the guidelines is almost the same in both age group. Under 6 years of age or up to 18 years of age. This first symptom screening, we should rule out active TB disease. If TB disease, if any suspicion is there, we can do chest X-ray or other investigation to rule out active TB disease. Then for less than 5 years of age, we can directly initiate TB preventive therapy. In above 5 years of age, as per NTEP, latent TB infection tests can be done. If positive, can be started on TB preventive therapy. If the test is not available, we can offer them and can also start them on TB preventive therapy.
Yes. So ideally above 5 years, they're asking us to, even if their child is asymptomatic, at least get an X-ray and a MAN2, and then offer the prophylaxis if based on the tests. So that is yes. So with that, I'll move on to the next. This case concluded as the X-ray was normal in the child, but MAN2 was positive. So we anyway gave the child the isoniazid prophylaxis. And please make sure that you complete a follow-up with these children because they have been recent contacts. So next we move on to case 3. This is a 3-month-old infant who presented following an acute life-threatening event. The child had a sudden apnea and seizure. So was initially managed in the ER, then we were trying to work up for a cause as to why this child had this. Metabolic parameters, X-ray, ultrasound, echo, everything was normal. During evaluation itself, child had another episode in the hospital. And so the thought process was, could it be an airway anomaly? And hence a bronchoscopy was done. So the bronchoscopy now picked up some compression of the tracheal wall at the level of carina. And the CT angio also picked up now some necrotic mediastinal nodes, which were actually compressing the bronchial wall. And that was what was causing the acute life-threatening episodes, depending on the postural variation. So now the problem is, now these parents refused a biopsy. So in this day and age, we always want to try and prove TB. We want to get a molecular diagnosis. We are so hesitant to start ATT empirically or giving a therapeutic trial. So when you are pushed to a corner like this, where it's a dangerous situation where you can't biopsy or the parents are not allowing you to biopsy. So what options do we have, Dr. Abhinesh?
Here is the clinical situation where the imaging, where the CT is suggestive of tuberculosis. There is a necrotic mediastinal lymphadenopathy. Now, next thing what we need is a microbiological confirmation. Father parents is refusing a biopsy. So I would try to get other specimens if available, if possible, resting gastric juice for CBNAT, and if any other peripheral lymphadenopathy is there, we can do a biopsy. If those tests also, if turned out to be negative, not possible, then we'll go back to the history and see whether the history and clinical features also favors tuberculosis, like failure to thrive, persistent progressive cough, or if there is any contact. If the features and also the imaging is suggestive of tuberculosis, I will label them as a clinically diagnosed tuberculosis and start them on ATT.
Okay, so you want to examine for other lymph nodes, try and get an easily accessible site if you could biopsy, or you said resting gastric juice. So we heard Dr. Tanu talk about the sensitivity and specificity. So anyway, we will ask Dr. Vaishnavi also. So we also heard about this tool expert, isn't it? So how exactly can we use these tests? RGJ, resting gastric juice and stool. What is the sensitivity and specificity of these tests?
So the sensitivity of the resting gastric juice it varies. It's about 70 to about 80 to 85 to 90% in various studies. The stool expert has a much lower sensitivity. It is only about 50%. So, and it is still not like in routine practice. So it definitely has a lower thing, but if there is no way that you can get a gastric juice sample or something, only then we can plan to use for stool expert.
In child like this, probably it's,
Yeah, some
can't
child
do
like
anything,
this,
then maybe
correct.
you could use it. So again, so in spite of all these things, we did hear from Dr. Tanu that the sensitivity and specificity of these tests are slightly lower. It's when you're talking about stool, it's around 50%, and it's even resting gastric juice, she said, was around 60 to 70%. So you still are going to miss out on quite a few patients. So now sometimes you're pushed to make a diagnosis of clinically diagnosed TB and start the patients on anti-TB drugs. So like, how careful should one be in these situations, and what do you anticipate? What problems do you anticipate from Dr. Janani?
Yeah, I think it's a very difficult question. Of course, we do face such situations in clinical practice. I think we should really, it's case to case. You cannot decide this. I mean, make it as a standard statement. Case to case, it will vary. And I think you should, like Vaishnavi mentioned, look at the other evidences like failing to thrive, the history of contact and loss of weight. And a manto may help in this situation. A manto positivity will be help of, and I think tracing the contact. If you have such a situation, and I think you probe and try to trace the contact, sometimes you may be lucky, as in this case, contact may be positive. And I think you're not wrong in labeling. If you've ruled out everything else, you're not wrong in labeling them as clinically diagnosed, and then start on treatment and probably look at the therapeutic response. I think again, it's like it's not that's done usually. Very rarely do we write clinically diagnosed, and we make ourselves, before we pen and write clinically diagnosed, we really question ourselves whether we've missed anything else. I think that's how it is. Yeah.
So that's what. So I think the take home that we're trying to say is try as much as you can to try and get a sample. Some samples. So we have so many options now that we learned from Dr. Tanu's talk also. So you should try and get some sample to prove that it is microbiologically proven. And again, if you are starting a child on a clinically diagnosed TB, or like say a therapeutic trial, please make sure that you keep the child on your follow-up. Suppose this child develops drug reactions and all that, it's going to be a little messy. So try and avoid as much as you can. And if you're doing it, please keep the child on your follow-up. So this child actually, yeah, this is Dr. Dhana's case. So they did a very nice thing. They screened all the family members, and then they found that one of the grandfather, if you ask the history, nobody will say that somebody is coughing in the house. But if you go and actually screen them, then only you will pick up that there was a contact who had a nice big cavity sitting there. And then though the baby's gastric juice was negative, now you have a grandfather's sputum, which was expert positive. So at least based on this, you know that this child, it gives you more confidence that probably what this child also is TB. So now this child was started on HRZD and steroids because he had airway compression, if you remember. And then this child improved very well. So what we want to convey through this case is that there will be situations where you will have to do a clinical diagnosis. So try and see what all you can do, how much other information you can gather, look for other sites. As Dr. Abhinesh was telling, look for any other site from which you can easily biopsy. Look for other samples like RGJ, stool, what all can you do? And screen the family and see if you can pick up an active contact. And that also will help you to give you confidence to start ATT in your patient. The next case is a 15-year-old child, a girl who presented to us with high-grade fever, chills, cough, and for 7 days. The parents had themselves given azithromycin at home for 5 days. And then on day 8, they met a local doctor who again gave cefuroxime for 2 days. By day 10, her fever was not subsiding, and that's when she came to us. So her weight was 45 kilograms, no significant pallor or notes. She was very comfortable. No respiratory distress, no tachypnea, but when auscultation, she had reduced air entry with no added sounds. And this is her labs. So hemoglobin is slightly low, WBC is normal, ESR is elevated 109, and X-ray is there for us to interpret. There is what looks like a right lower lobe consolidation with a cinnamonic effusion. So with this, the child started on ceftriaxone and linezolid. Okay, so we heard Dr. Tanu talk about it. So let's see. So I'll first ask Dr. Abhinesh. So what are your likely differentials in this child who's come to you with a 10-day fever, with what looks like a right-sided pneumonia with a cinnamonic effusion, and the labs I have shown you?
The history is almost 10 days of fever, and that it is gradually progressing. And the child is not sick, and there is not much of respiratory distress. The possibility is a complicated pneumonia with right-sided effusion. Still, the tuberculosis also another possibility, as there is a 10 days history of fever and the gradually progressing course. So I'll have tuberculosis also in my mind and the complicated pneumonia.
Yes. So between tuberculosis and pneumonia, you think that a pneumonia child would be more
sick looking, and they will be acute and rapidly progressing, and they will be having distress, tachypnea, and toxicity will be more, which is not here in this child.
Yeah, likely. So these are the two common differentials that we would think of in the bedside. Obviously, there are many other reasons that the child can have, but then probably these are the top two things. So again, this is worth reiterating again and again. Linezolid as empiric choice. Even now, there is a practice that we use linezolid in community-acquired pneumonia, complicated effusion. So what do you want to say about that, Dr. Vaishnavi?
So linezolid should be reserved because it is a second line treatment for tuberculosis. So there is no need to give linezolid as an empiric choice because pneumonia, you're going to think mostly of something like strep pneumoniae. In this particular X-ray, especially, there's nothing like nematoceles or cavitation, multilobar shadowing, or if you like a pneumothorax, which should warrant us to think of staph. Even then, we have alternatives to treat staph, and there is absolutely no need. You should not be giving linezolid at all. Even surgeons we have seen for abscesses and all have been giving linezolid, and after multiple requests and antimicrobial stewardship, now that has reduced and stopped. But linezolid definitely should be reserved because it is one of the very important drugs in the second line treatment of TB.
So it is an excellent TB drug. So we try and limit it empirically. So if you have a proven staph aureus and then you want to use linezolid in a child, nobody is going to argue with that. But starting all sick pneumonia children or abscesses children with empiric linezolid is calling for trouble. Okay, so now we are Dr. Janni. So now anyway, this child is on ceftriaxone linezolid. This child is not improved. So what would you want to do next?
Yeah, I think we'll go ahead with an ultrasound of the chest, which will tell us whether it's just a fluid or whether there are any loculations inside. And then that will differentiate between tuberculosis and bacterial, other bacterial infections like complicated pneumonia. Then, of course, a diagnostic pleural aspiration. You can do a diagnostic tap and then try to send the pleural fluid for expert and also the protein and sugar and probably a smear for AFB and culture. Yeah. So that's how we'll proceed. Yeah.
So this is again something very important. When you have a pleural disease, I think the imaging of choice is ultrasound. So anyway, this child got a CT chest done, which again showed a moderate right pleural effusion with passive atelectasis on the underlying line. So that's sort of very typical again, isn't it? So you don't have an underlying consolidation on the CT. You just have a big significant pleural effusion causing a collapse. So now, Dr. Abhinesh, again, do you think this you should put in an ICD? Should you do VATS? What is the next step? Dr. Janni says that she wants tapping. So would you call in a surgeon at this point, or what should be the next thing? So clinically, we were thinking between complicated effusion and TB. So what does the CT suggest to you?
Yes, ma'am. Again, the CT, there is no underlying consolidation. This is again pointing towards tuberculosis. I will get an ultrasound, and that also will make sure there is no localization or septations. And then we'll proceed with if TB is high likely, there is no need for a surgical intervention. There is no need for ICD. We'll directly go ahead with diagnostic tapping, fluorescences.
So again, the CT should convince us that it's more likely to be TB because there is no underlying consolidation. So if you call a surgeon, definitely they are going to do that. So they are going to put in an ICD. So that's not what we want. We want to do a pleural fluid analysis. And see, the fluid analysis was showing cell counts with lymphocytic count and then protein LDH elevated, gram stain and cultures were negative. Luckily, in this child, the pleural fluid was positive, expert positive, and RIF resistance was not detected. We did listen to Tanu on that, but still, sensitivity of expert MTB on body fluids. What's your take, Dr. Vaishnavi?
So it is actually quite low. Sensitivity of, for example, in like pleural and ascitic fluid can be as low as 15-20%, very rarely up to 40%. So one message that we should take is to not say, oh, this is not TB just because GeneXpert is negative in other body fluids. It's very good, the sensitivity specificity for gastric juice, aspirate, sputum, etc. But for other body fluids, such as pleural fluid and ascitic fluid, it is quite low. So if otherwise clinically, radiologically, the child is fitting in with tuberculosis and your pleural fluid analysis is also supporting that, just because expert is negative, I would recommend not, labeling the child as not TB because the sensitivity is poor in these cases.
Yeah. So then, see, now we have one hand, we are saying that we should not do clinically diagnosed TB. We should try and get a microbiological diagnosis. And then we're saying pleural fluid sensitivity is low. So what does that mean? Do we do biopsies in all these children? So what is practically done, Dr. Abhinesh?
The yield of pleural biopsy actually quite good in TB pleural effusion. But this much evidence from clinical history and investigation and tapping, that much is actually enough to treat a child with a TB pleural effusion. But if there is a doubt, if our closest DD is malignancy like lymphoma with effusion, we don't have any other site for biopsy, we can do a pleural biopsy and see, try to confirm the diagnosis.
Yes, point well taken. So this child was very straightforward, looked like a, and anyway, her expert was positive, but even if expert was negative in this child, it looks like it was looking more straightforward. You just sort of didn't have many alternative diagnoses, but even if there is a slightest of suspicion, I think we should go ahead and get the biopsy. It is worth it. Point well taken. So this is just to summarize, this is there in our NTP guidelines. So generally for pleural fluid, only in culture positive specimens, the sensitivity is 40% or so. Otherwise, it's very low. It's only 10%, 20%. So fluids are not very good samples, but generally tissues, even aspirates, like lymph node aspirate, gastric aspirate, pus, CSF, they all are very good samples. But again, it's not 100% sensitive. So it's not a rule out test. It's only a rule in test. So this child was started on first line ATT, and then her cultures also grew. So probably that's the reason why her expert was positive. And at 2 months, she just, we switched her to HR. So again, when your cultures are positive and INH is sensitive, then you need not continue the ETAMP at all in the continuation phase. You can safely switch to H and R and finish the 6 months therapy. So now the next case is a 5-year-old girl from North Chennai. She was previously well, fever for 9 days, poor appetite. And by day 9, this child starts to become more dull and is wanting to sleep. She also now starts developing new symptoms like a generalized headache and some vomiting. With all these things, she gets admitted outside for 3 days. So I think the clinical or the working diagnosis was enteric fever. So she got ceftriaxone. No brain imaging. So it was not thought to be a primary brain process. So imaging wasn't done. And we didn't have many labs from outside. So when she presented to us, her GCS was 14/15. She had some neck stiffness, but no focal neurological deficit. And fundus examination was normal. Other systems were normal. There were no significant lymphadenopathy or rash. Her anthropometry was also within the normal range. So Dr. Vaishnavi, so what do you think is going on? This child has what seems to be a little bit of a subacute illness with some encephalopathy, with some neck stiffness. So what do you think is going on with this child?
Yeah, so the description fits into like a meningoencephalitis kind of picture, meningitis kind of picture. So since that girl is from North Chennai, epidemiologically, we should keep in mind that malaria is quite common in that area. And she has been having a subacute illness. So I would keep cerebral malaria as one of the DDs. And scrub typhus can also present similarly. It can be a partially treated meningitis because she has received antibiotics outside for about 3 days. And again, since it's subacute, definitely tubercular meningitis we should also think of.
But malaria, do you get neck stiffness? So she did have some neck stiffness. So probably, yeah. Anyway, you would keep in mind because of the acute.
You keep in mind, yeah, because of the subacute.
Probably lower down. So maybe, as you said, partially treated. Scrub typhus, yeah, can be a very close differential diagnosis to your subacute meningitis. So again, hemoglobin was normal, WBC count, nothing much happening. CRPSR normal, MPQBC anyway was negative, and scrub IgM was also negative. This one, we went ahead and did an MRI which showed diffuse septomeningeal thickening with basilar enhancement. And this is a CSF. CSF is now showing 110 cells. It's lymphocytic. The sugars are low, 24 compared to a CBG of 110. Protein is slightly high. But then the ME panel, which was done, as we were thinking of whether it could be a partially treated pyogenic, then this now shows it is HHV6. So now I think I'm going to ask Dr. Janani. So what do you think this is? Is this a partially treated pyogenic? Child did get ceftriaxone outside. Or is it HHV6 or some other viral meningoencephalitis? Or should we think of TBM? Like what should we do next?
Yeah, I think I would straight away rule out viral because HHV6 is not the one that causes viral meningoencephalitis. I would keep partially treated pyogenic meningitis as one of the DDs because that's quite possible. She's been on ceftriaxone from day 2 of illness. I would also not, I would also like to keep tuberculous meningitis as the next close DD, because as per your algorithm, she satisfies the criterion 1. She has the clinical and lab and imaging features of meningitis, tuberculous meningitis. Of course, we do not know at this point of time whether she has a history of contact, and she doesn't have any underlying risk factors. Like, we don't know the HIV status of her, and other evidence of TB elsewhere is there. The criterion 2 and 3, if we satisfy, I think she'll definitely, I would keep tuberculous meningitis as my very close differential diagnosis to partially treated bacterial meningitis.
But the way it started, yeah, it could still be both. It could still be partially treated pyogenic, but somehow it was not very acute to start with. Sort of started a little slow and then it built up. But still, we should keep that in mind. Yeah, so this is what we did. So we went ahead and did a gram stain and a P stain, which was negative. On the CSF, this is, she did have a HIV ELISA, which was negative. We looked for other focal areas for TB. So we at least did an X-ray and an ultrasound, both of which were normal. And again, sometimes it's important to get an off-thal evaluation. If you do an off-thal evaluation, sometimes you might pick up clues like choroid tubercles and all that, which again was normal. So we actually didn't get anything on her. And the CSF expert MTB ultra, so we have switched to using this. So we did an ultra, which is more sensitive than, say, the expert MTB, if still it was negative. So if you have a situation like this, and say if you have started this child on antibiotics, so some of us would just give some antibiotics and repeat a CSF to see if she is still worsening on antibiotics, and then we would maybe if
so this girl has a leptomeningeal enhancement, basal exudates, and then the CSF findings like lymphocytic predominance, low sugar. I think I would definitely start ATT, because she's already into 9th or 10th day of illness, and there is not much of improvement with ceftriaxone. Sure. And you don't have the cultures growing anything by now. I think we should not wait anymore, because the only dreadful thing in tuberculous meningitis is they develop sequelae. Yeah, because the child can lose the vision, or the child can have a stroke kind of features, or can have cranial nerve involvement. So I wouldn't like to wait. Yes. I would probably start ATT and probably later on stop, but not wait for starting ATT.
Point well taken. So already we have lost about 10 days by the time we have done all this. And ma'am says if you wait any longer, she's only going to worsen. So if you have enough data in hand, probably most of us would not wait, just start therapy. So now we said expert ultra is so sensitive and specific, but why did it miss in this child? So why did we not, if we think it is tuberculous meningitis, so why is it not picked up anything? Dr. Abhinesh.
As we have heard from the Tanumam's lecture, the sensitivity of expert ultra is very high when compared to expert MTB. It is almost double in CSF specimen. The specificity is little less. But the CSF volume which is required for testing is normally for an expert MTB, ideally 8 to 10 ml of specimen is required. For expert ultra, we need a minimum of 2 ml. So that would be the treatment.
Yeah. So we in this trial only 0.5 ml was in. So that's very important. The volume that you send, please make sure that you send at least 2 ml of CSF for expert ultra if you're using it. Using expert MTB, the old or the RIF, then at least 6
8 to 10 ml.
Or even 8 to 10 ml is preferred. So probably one reason why such a sensitive test can miss is if we are not good with the sampling. So anyway, this child did not cause us much trouble. The father did have a history of PTB. Again, he had received ATT, but unfortunately, this is a very common scenario. The household contacts never get screened for adults with pulmonary TB. So this child was not screened, did not get prophylaxis, and hence landed up with TB meningitis. So this child was started on HRZD and steroids, improved on ATT, and we're just planning to finish 1-year therapy. So this is again a case of a 15-year-old girl, the same pleural effusion. So I'm just using it as another case. So she was started on HRZD for left pleural effusion. Expert was positive, as I said. But now, after 3 days, she started complaining of nausea, vomiting, and poor appetite. So with this, she visited her neighboring doctor, who first gave her some proton pump inhibitors and some antiemetics and reassured, and she was sent home. She did not improve on that over the next 2 days. And again, she went to the same doctor who now said that please take your medications after food. Maybe it's because you're taking it in empty stomach, you're having some gastric intolerance. So then later, after that, after almost a week, she came to us. And then by the time we did her LFT, it was all in the hundreds. So this was a pure case of a drug-induced liver injury. So this is something that we should keep in mind whenever we start. So when they complain of symptoms. So like, how commonly do you see this? We always think that drug-induced liver injury is not something that we see in children, isn't it? So Abhinesh, how common is this in children? And are there any children with risk factors that we should really be worried about?
Of all the adverse events, DILI is most common. It comes around up to 10% of children who are started on ATP. This is quite common in children with TB meningitis, or children who have severe hypoalbuminemia, or if there is any co-administered hepatotoxic drugs. Very less significant risk factors would be malnutrition and HIV infected children.
So yeah, it is something that's not unusual. So you still have to look out for. So how would you manage a case like this? If she came in, Dr. Vaishnavi, so if you had a child who comes to you with liver enzymes like what I quoted, so Dr. Vaishnavi, she's not. Madam, you can take up, ma'am, if it's okay.
Yeah. So I think, again, to stop all the, if the child is sick, like TBM child, then I wouldn't stop. I would stop all the drugs and then start second line drugs and can retain ethambutol alone. And then probably introduce one after the other in the order of rifampicin, INH, and pyrazinamide. We at weekly intervals by repeating the liver enzymes every week and make sure that, find out which drug caused the problem. And I think by the end of 3 to 4 weeks, we can probably reintroduce the drugs. And if the child is a non-severe extrapulmonary tuberculosis or pulmonary tuberculosis, I would just stop all the drugs. I wouldn't give second line.
Yeah, so we'll take it.
And of course, do a hepatitis A, IgM also, because the co-infection with hepatitis A virus is also common.
Yeah, so generally the recommendation is if they are asymptomatic and if it's more than 5 times the elevation, and if they are symptomatic, then even more than twice or thrice the elevation is considered significant as drug-induced liver injury. And then, as Madam said, depending on the severity of the patient, you would either start second liver sparing regimen, or you would just wait and then reintroduce step by step and finish the therapy.
Hi, am I audible now?
Yeah, Dr. Vaishnavi.
Yeah.
Oh, you lost me in between.
So
I think
I
you
answered.
you finished.
Okay,
Okay.
I think
We
yeah.
finished.
Sure. Okay, I heard
Yeah.
Dr. Janani was
Yeah.
answering. All
Dr.
right.
Jani, ma'am, the next question also, but there's something like now we are continuing ethambutol in the continuation phase also. So often we are worried, when should we screen them? Should we regularly screen them, or should we wait for them to complain of symptoms? So are there any recommendations on this?
Yeah, the Indian Ophthalmological Society has got played. Whose dog is barking behind? Please mute. Abhinesh, your dog, huh? Yeah. So the Ophthalmological Society, the ophthalmologists are more worried than the pediatricians. They feel that we are not screening them regularly. Ideal guideline is to screen them before starting ATT once, and then just like how you document your liver enzymes before starting, and then in between treatment, maybe on the 3rd or 4th month, once again, and then at the end of treatment. So thrice we'll have to screen them. And it's not just ophthal screening. You should also do the visual evoked potentials, and also the color vision screening has to be done. So that's what is the recommendations here. But I think in practice, we do it in between treatment once or once after finishing treatment, unless they complain of something. Usually they don't complain. Color vision, loss of color vision and field vision and all, children don't complain at all. But it's only with testing you can find out. Yeah.
Especially if you're doing a 1-year therapy and all for TBMC, please make sure that you at least get it once or twice tested in between. We have had one patient at least in practice where we picked up subclinical. It was subclinical, but only when we screened, we picked it up. So it's important to keep an eye on that. So the next case is again a 3-month-old infant. who comes with a fluctuant swelling at the BCG site, quite significant. No axillary adenitis, hepatosplenomegaly, no failure to thrive. Child is otherwise well, firstborn of a non-consanguineous marriage. Already went to the surgeon. Surgeon has drained the abscess, and the child, he refers to you with these reports. The smear is positive, AP smear is positive, expert MTB is positive, RIF resistance is not detected. So what do we want to do, Abhinay? Should we just start this child on ATT, or what should be the approach in these patients?
In these infants who have a local BCG site swelling or any BCG adenitis, if the children is otherwise well, if the baby is otherwise well, like this baby, otherwise well baby, no failure to thrive, no other constitutional symptoms, if the swelling or the reaction is mild, you can just wait and watch or observe. The swelling is quite big, or if there is any suppuration, you can they can aspirate. Sometimes they require multiple aspiration. If it is quite big and if there is multiloculation, they can do IND, and just that IND itself is enough.
So is there any role for ATT, antibiotics, erythromycin?
There is no need for ATT. If it is secondary infected, the first or something, they can start an antibiotic. Otherwise, not recommended.
Yeah, most of the times it's sterile, so you just don't do anything. Yeah. So now, Vaishnavi, so sometimes we have to be worried because this can be an early manifestation of, say, a SCID or a T cell deficiency. So when should we worry about a child like this having an underlying immunodeficiency?
So if this child has been somebody who has had persistent pneumonia, recurrent pneumonia, if there have been frequent infections, if the child is failing to thrive, oral thrush, hepatosplenomegaly or lymphadenopathy is detected on examination, or labs are showing like neutropenia, low platelets or low hemoglobin, or there's been history of sibling death, things like that should prompt us to look for other immunodeficiencies which can lead to disseminated BCGosis. But in this case, actually, there has been none of those. Like there's no failure to thrive, and you have mentioned there's no axillary lymphadenitis or hepatosplenomegaly. So I would not suspect particularly in this child, but I think generally these points we should keep in mind for not just SCID but also CGD and even MSMD, which is that Mendelian susceptibility to mycobacterial diseases. In that they can have a bad disseminated BCGosis, which can even cause death. So we should just keep those in mind.
Yeah. Very important. Those children need early referral. Sometimes they go about taking ATT, but nobody refers thinking that these children need workup and transplant and other things. So if you have a child who has a disseminated BCG disease, see, in those patients, expert will be positive. But if you are in the habit of culturing, you will see that the Mycobacterium tuberculosis complex, which grows, is resistant to pyrazinamide because the BCG strain is resistant to pyrazinamide. So if you see something like that, then please think of BCG and kindly refer those patients early for immunological workup and transplant. So this is the last case. I think somebody had asked in the chat box. So hopefully this answers your question. So now you have a mother who's diagnosed with pulmonary TB near term. Her sputum expert is positive as well as AP smear is positive. She's been started on HRZE, which is safe in pregnancy, but she's not even had, she's probably had only a week of therapy, which means she is still likely to be infectious, and she delivers the baby by then. The baby herself is well, clinically well, birth weight is 3.5 kgs, no hepatosplenomegaly. So madam, what should be the approach? What do the guidelines recommend in these situations?
So the guidelines are very clear. This mother has got a pulmonary TB, sputum positive. So the baby is fortunately thriving well. I mean, weight is good and there is no hepatosplenomegaly clinically, but we should also do the radiological evaluation and an ultrasound to see whether there are any nodules in liver. If everything is ruled out, I think we should go ahead, give the BCG vaccine and start the child on INH 10 milligram per kg for 6 months along with pyridoxine. But even if this mother has had a extrapulmonary TB, the same thing applies. So this is fortunately pulmonary TB, but the program says pulmonary TB or extrapulmonary TB perinatally, even if the mother was treated during pregnancy, at some point of time you're supposed to start this child. I mean, the same protocol you have to follow. Rule out active disease in the baby. If there is active disease, treat as tuberculosis. If there is no active disease, then give BCG vaccine and give prophylaxis.
How about breastfeeding, ma'am? This mother is still...
Breastfeeding can continue. Mother can wear a mask and continue.
Yeah.
Because this mother is a pulmonary tuberculosis. she'll be infecting the child if she doesn't wear the mask. So I think close contact with the baby for at least for the first 2 months, she has to wear the mask and continue to feed the child. Yeah.
Okay, I think with that, we come to the end of this panel. So I see there are some questions in the chat box. So maybe we should try and answer them as well.
Yeah, most of the questions in the chat box is answered in the questions itself.
Okay.
Excellent.
Running out of time.
Yeah, it's okay. So
everything is, I think
one thing I just want to add.
Tanu's lecture answered most questions.
Yeah.
And
Madam has also answered the questions also.
Yeah. So I think we have actually reiterated whatever Tanu said. Tanu, you have any comments? You can ask Tanu whether she has any comments.
No, I think it was excellent that the cases were very good, and these are the day-to-day situations which pediatricians face, and all of them were covered, including CNS, TB, drug-induced hepatitis, and the various dilemmas. So I think everything has been covered. I think I would just like to make one comment, because my talk was only on updates, but in clinical practice, I think we should go all out in making a diagnosis.
Yes.
As far as possible, we should make all efforts. If we don't have the facilities, then we should refer the patient. Yes. But understanding very well that despite all these efforts, in 50% of the cases, we won't be able to prove it microbiologically. But then it's fine. Once you've made the effort, it's okay to then go ahead and give empiric therapy, but we should make that effort.
Thank you. And one more thing I just want to add, in case of lymph node TB, most of the time we see only FNAC was done, and with granuloma, they are starting ATT. But only granuloma is not equivalent to TB. You discuss with the pathologist. If it is a caseating epithelial granuloma, then it confirms. Otherwise, we had few cases where lymphoma is missed and even Kikuchi is missed. So
discourage FNAC and do excision.
Yeah, definitely excision biopsy. But if you tell, they say we have no facility.
But that's a big argument. FNAC.
This should not be the answer.
People vouch for FNAC.
Actually, somebody had asked if FNAC showed reactive nodes, what to do. So basically, if you're looking at reactive nodes, please make sure that you get a biopsy, and FNAC is good.
Always try to make an excision biopsy. Yeah. If FNAC, you get a GeneXpert positive, then you can start. You are permitted to start.
Dr. Kanna,
but I would like to add one thing.
Something to say.
So, that question which was asked now, they did FNAC and it showed reactive nodes, but we should look at what node are we doing an FNA from.
Yeah.
Because there are so many children who will come with cervical nodes which are less than 2 centimeters in size. And when you do a sonography, you find that there's an intact hilum. There's no necrosis. In such cases, you shouldn't go around doing FNAC. So you have to select that case properly. And if the FNAC doesn't show shows reactive adenitis, then you should do either a core or excision biopsy. We have recently started doing core biopsies in these patients, and that has obviated the need for an excision biopsy. Because core biopsy, you get a big, larger amount of material, and you are usually able to reach a diagnosis.
There are two questions from Dr. S. Ramesh has asked, if MAN2 is 10 mm positive in asymptomatic child and no contact history, chest X-ray is normal, how to proceed?
Don't do anything.
Yes. And Dr. Mahadevan sir in the panel has asked, what is the percentage of TB meningitis in stage 1 to 3 and current Indian data?
Most of them are stage 1 to
Stage 1 gets.
I think depends on where you are practicing.
we can't say Indian data unless you have published data. It's very difficult to question. Yeah.
That was really awesome. From the delegate side, complete from the start to the end. It was so good. And I think for the delegates and for the people who are, you can also get the recording in the YouTube. So that would be for the postgraduates and for the practitioners who have not listened to it. And still watch. Yeah. Over to the sorry.
Yeah. So any other queries?
No.
I just had one comment. Yeah. There are still so many scenarios which we could not cover. So, Dana, please, we should do a part 2 with somebody.
Yeah, do it, and we'll definitely plan for it.
We will definitely do part 2.
We are planning like that only to have the Janani ma'am has clearly said have it one thing. She started it starting from the flu, respiratory pathogens, fever. We'll be going like that way only.
Specifically told Dr. Vidya cover first. We will cover the common things first.
Then we'll go further.
This tuberculoma and all those things. Always there is confusion. So we should do
Definitely.
some.
We're also planning for some midterm CME. Let's see how it comes through.
Yeah. We'll do that. Yeah.
So now I request
Thanks, Tanu. Thanks for your valuable time.
Thank you.
Thank you.
Ma'am,
Now
Dr.
I
Murugesh.
request
Yeah.
our
Thanks
treasurer,
to,
Dr. Murugesh and
Vaishnavi.
Ma'am, Dr.
and
Murugesh
Abhinesh
Lakshman has
were
joined,
excellent.
madam, our treasurer. Yeah, over to him.
Vaishnavi and
Over to
Abhinesh
you.
were excellent. Thank you, both
Thank
of
you
you.
so much, ma'am. Thank you for the
Yeah.
opportunity.
Dr. Murugesh Lakshman, Dr. Tana. Sir, you're muted. You're muted.
That's all.
Sir, you're muted, sir.
You show like this, otherwise they will.
Okay. First of all, I'd like to thank all our faculties for immediately consented to do today's session at short notice. All the sessions are very wonderful. Actually, I joined a little bit late as I was coming from Bangalore. And if the first session concentrated on all the updates, the second session was on clearing many of our doubts which we face in our day-to-day practice. So we hope to bring many more such sessions in the near future. Incidentally, this is our first program of a year. And I would also like to thank IAP TNSC for your collaboration and for having consented to use their Zoom platform for this program. So once again, thank you. And I also thank all the delegates for having joined in large numbers. So thank you, good night, and hope to see you in the next program. Thank you.
Thank you, Dr. Murugesh Lakshman.
Very
Thank you
well.
all.
Thank you, Dana, for
Good
hosting.
night. Thanks, Vidya.
You did really great, Dana. You did really
Thank you.
great.
Dana,
Thank you, all the
Dana,
faculty.
congratulations for a good start.
Thank you, ma'am. Thank you. Dr. Tanu, thank you so much.
Yeah, Abhinesh, your
Thank you.
dog, feed your dog. Yeah, it's barking.
Sure, ma'am.
Please remind me the time. The time is over.
Check. Okay, bye.
Thank you, ma'am.
Thank-
Thanks.